So we're going to take a look at the respiratory and circulation systems, and hopefully you'll have a memory of these from your previous A&P courses. So if we have a look at the picture on screen here, we can see there is a picture of a red blood cell. It's carrying oxygen via hemoglobin molecules, with the oxygen bonding to these hemoglobin molecules. The blood travels off to the cells. The hemoglobin releases the oxygen to the cell's tissues. A quick review of the pulmonary system shows us where this initial oxygen bonding happens, and we can see there that we go into the deep heart of the lungs, and we can see that we've got little blood vessels, little blood capillaries laying right next to the alveoli, and that's where the gaseous exchange occurs. And we'll look at gaseous exchange a little bit later on. So there's four main factors that influence the adequacy of circulation, ventilation, perfusion, and the transport of respiratory gases, and these are listed for you on the screen. These are physiological, developmental, behavioural, and environmental factors, which we're going to discuss a little bit in more depth. What is a physiological factor? Now, this can be any condition that affects the cardiopulmonary functioning and directly affects the body's ability to meet its oxygen demand. So, for example, if someone was in a car crash and therefore was in a state of hypovolemia due to large blood loss, then they would have reduced circulating blood and therefore a reduced capacity to carry and transport oxygen. The last point on the screen there is conditions that affect chest wall movement, and this will subsequently result in decreased ventilation. So if we think about the diaphragm being unable to descend fully when breathing, the volume of inspired air will decrease and thus delivering less oxygen to the alveoli within the tissues. This slide shows a few examples of such conditions, with things such as pregnancy, obesity, and pain being the most common. Here we are looking at developmental changes of the patient, with changes occurring over the lifespan of the patient, with age affecting tissue oxygenation. Premature infants, for example, at a high risk of membrane disease, which is caused by surfactant deficiency. So the surfactant of the lungs develops late in pregnancy, about the 7-month mark, and therefore may be lacking in preterm infants born before this time. Infants and toddlers are often at a greater risk of upper respiratory tract infections or URTIs and airway obstruction because they're always trying to cram things into their mouth. School-aged children and adolescents are often exposed to respiratory infections, secondhand smoke, and they might even begin cigarette smoking themselves. Now, the young to middle age adult may start to feel the effects of poor health choices, such as unhealthy diet, lack of exercise, stress, and again, cigarette smoking. And then lastly there, we have the older adult, and they will often have calcification of their valves, cardiac conduction problems, atherosclerosis, and myocardial muscle thickening. Behavioural factors are a little self-explanatory, with mention just given before when talking about the young and middle-aged adult patient. As you can see on the screen, some examples are obesity, which might cause cardiopulmonary problems. Malnutrition might have problems for healthy cells, tissue repair. Exercise, now initially that will have a high demand for O2 during exercise, but ultimately that will improve the fitness of the cardiopulmonary system and therefore will be a large benefit. Lastly, there is stress and anxiety, which increases metabolic rate and oxygen demand, with things such as self-care and health and well-being programs put out there to try and mitigate some of those issues. Environmental factors can best be seen during bushfire season and the effects to the public when they have to breathe in that smoke from those bushfires. Climate change and cuts to greenhouse gas emissions, they continue to be on the global and political and social agendas because of the large impact on the population health and well-being that these environmental factors can bring. Now, as I said before when we were having a look at the picture of the alveoli and the capillary bed right next to there, oxygenation needs two main things to be effective, and that's adequate ventilation, so the airflow to the alveoli, and adequate perfusion, which is the blood flow to the alveoli within that capillary. And this is called ventilation perfusion ratio. Some reason it's called a VQ ratio, not a VP, but anyway. So if there's an impairment with either of those mechanisms, there might be a VQ mismatch, and that will result in a lowering of oxygen availability. As we can see there in the first picture, we've got normal appropriate oxygenation and appropriate ventilation and perfusion. So our alveoli is open, it's full of air, and that's able to easily have gas exchange with the capillary, which has got adequate perfusion, full of blood. The second picture there, we've got decreased ventilation. So in this example, we might have pneumonia. So we've got mucus, pus, whatever we've got in our lungs, and they've come down into the alveoli, causing a blockage there for our air and the oxygen to get into. And if we can think of that air trying to rush through that pneumonia, that mucus, it's going to be really, really difficult to have that appropriate gaseous exchange when we don't have a nice air-filled alveoli sac to be able to interact with that capillary bed. Then later on, we might have a perfusion issue. So our alveoli is open, there's no barriers there to stop that gaseous exchange. The issue being is there's no blood there to actually have that gaseous exchange there, because in this example, we've got an embolism. Whilst we might have a alveoli sac full of air, full of oxygen, it's actually got nowhere to go. So I'm only putting that out there just in case you hear VQ mismatch or VQ ratio within your clinical placement. Some respiratory terminology we may come across there is on the screen. So the first one, hyperventilation, is the excessive ventilation which is well above what the body needs to eliminate carbon dioxide. That's often caused by things such as anxiety, infections, drugs, acid-base imbalance, fever, or even aspirin poisoning. And the issue there with hyperventilation, when we're breathing too much carbon dioxide out, carbon dioxide is one of the regulators of our breathing, and if we breathe off too much carbon dioxide, that might have larger consequences for our breathing overall. On the flip side is inadequate ventilation, so hypoventilation, and there's not enough ventilation happening to meet the body's oxygen demand, and this can often be caused by atelectasis or collapsed alveoli. The bottom left there, hypoxia, is the inadequate tissue oxygenation at the cellular level and can be, if not treated appropriately, life-threatening. So one indication of hypoxia, and the one that we may notice first, is cyanosis, which is the blue discoloration of the skin and the mucous membranes, and I'll show you a picture of those just in a moment. So aside from cyanosis, which we just mentioned being a sign of hypoxia, other signs and symptoms of hypoxia can be remembered with the acronym RATBED, which is the picture there on the right of your screen. So early signs will be restlessness, anxiety, and tachycardia and tachypnea. And then later signs being bradycardia, extreme restlessness, and dyspnea, which is shortness of breath, or sometimes described as air hunger. So as I said before, I'll show you some pictures of cyanosis. So the top picture is the baby showing central cyanosis with blue discoloration around the mouth and lips, and likely if we had a better look would be a cyanosis of the tongue. And then the bottom picture is peripheral cyanosis with blue colors to the fingertips. Some illnesses and conditions that affect cardiac rate, rhythm, strength of contraction, and blood flow through the chamber and peripheral circulation system will cause altered cardiac functioning, with altered cardiac output likely causing left-sided or right-sided heart failure. So the first one we can see there, disturbances in conduction, which is when there is an issue with our electrical impulses within the heart. From my experience in pediatrics, a really common one is supraventricular tachycardia, when there is extra electrical activity causing the heart to beat faster than it should, sometimes up to 200 beats a minute. Now the problem with a disturbance in conduction and the heart beating too fast is that might have an effect on the cardiac output. So in supraventricular tachycardia, if your heart is beating 200 beats a minute, it means that your heart isn't being able to refill adequately, and therefore when it contracts and when it ejects blood into the circulatory system, there isn't enough there that's needed, which may cause heart failure if, again, left untreated. Valvular dysfunction can cause a black flow of blood, and if we were to have a listen to the patient's heart, we might hear a murmur or a whooshing sound. Common myocardial diseases might include angina, MI or myocardial infarction, or acute coronary syndrome or ACS. So let's now have a look at some of the assessments needed in relation to respiration and circulation. So a nursing history is always a good place to start, with many of the questions possible to get a better picture of the patient and their history. So many of these topics that are on screen would be self-explanatory as to the importance and why we would collect them. So remember, dyspnea is shortness of breath, or what people might describe as air hunger, with orthopnea being that the patient needs to sit or stand to breathe comfortably. You will likely have heard of the tripod position, where patients either sit or stand upright and they slightly lean forward. If you see patients like this, make sure you leave them in whatever position is comfortable for them, as moving them or asking them to lay flat might have quite large consequences for your patient and their respirations. I'm not going to tell you why, but I would really encourage you to have a look in what is the benefit for a patient in the tripod position. How does it actually help? What does it actually do for the patient that makes that breathing easier for them? So have a look in your book and see if you can come back and let me know. So we've done our nursing history, we've asked a few questions. Now we're going to have a look at some of the physical examinations. So inspection might include many factors, such as checking the skin and mucous membranes for color and appearance. So like we talked about before, when we talked about cyanosis, we might want to have a look at the mucous membranes for any blue discoloration. You might even look for breathing patterns and chest wall movement. Palpation, we're going to start to feel for tenderness, tactile fremitus. We might even palpate the feet and extremities for signs of oedema. So percussion, you can see the little picture there of someone drumming their fingers on a patient. Percussion is to detect the presence of abnormal fluid or air in the lungs. And the best way I can describe that is a little bit like finding the wooden stud in the wall. You might go and knock on the wall, and that hollow sounds mean there's nothing behind it, so that would be air. But if you hit on something that is a bit more duller, well, that would be where the wood is. And this example, in a patient's chest, that would be where some fluid or some collection of something is within the chest. So in addition to percussion, we might auscultate, so we're listening so for both heart sounds and lung sounds, and that's something you really need to practice a lot on healthy people to know what abnormal is. If you're only listening to abnormal lungs, for example, it's really difficult to know, well, what does a normal lung sound? So for anyone with their own stethoscope, I would really encourage you to go and listen to family, friends, or anyone who is willing. So heart sounds, lung sounds, even bowel sounds. Have a listen to people that are healthy. For anyone with a really fancy Littmann stethoscope, their website has really good resources that you can listen to different sounds, and it tells you what those sounds are. So if you're a little bit unsure of what you're actually listening for, that might be a really good place to start. So that's the Littmann stethoscope website. Now, I just want to show you on this picture, because you might have seen when you've gone to the doctor and maybe they've had a listen to you. Sometimes they listen at the back, sometimes they listen at the front. Now, I'm going to make this very simple. I know that there's lots of spaces that you would listen to, but you can see here that the lung isn't straight up and down. So it actually kind of tilts forward a little bit. And if we were listening to the higher lobes of the lung, it's much better to actually listen to the anterior, so the front of the patient. The main reason is there's actually more surface area that we can listen to, but also if we actually look at the top lobe of the lung and we listen posterior, the problem is that we would actually be going through the scapula. So there'd be a big bone there that we would dull some of the sound, so we wouldn't really be able to get a good understanding of what we can hear. If we then look at the lower lobe, so that purple lobe, why would we not listen at the anterior? Why would we not listen at the front? Well, firstly, we might actually be listening to the middle lobe. Secondly, we might actually be listening to lots of different sounds. We might actually be hearing lots of bowel sounds because that's kind of in the same area as well. So it might be that if we listen to the posterior of the patient, we've moved down from the scapula, and again we've got much larger surface area. If we look at that curve of the purple lobe, that we can actually listen to lots of different areas of the lower lobe. So just a quick picture to show you why we listen to the front on some lobes, why we listen to the back on some others. So in addition to the assessment that we're going to perform as a nurse, what tests might be important for the patient? So we can see there we've got a range of different tests, and we'll go through a few of them. Some of them again are going to be more than common, and we're going to know exactly what they are. So an ECG, for example, we've probably all heard of an electrocardiogram. So that produces a graphical record of the heart's electrical activity, and that detects any transmission or impulses and the electrical position of the heart. Now that Holter monitor is a portable device that can record the heart's electrical activity and produces a continuous ECG trace, generally over 24 hours. So normally the patient will actually wear that monitor when they go home, and it looks for, because sometimes you might have heard of things such as ectopic beats, which are extra beats that don't always happen quite rhythmically or all the time. They might only happen every now and then. So if we were to just do an ECG in-house, so when the patient is with us, we might miss those kind of things. But sending them home with a 24-hour Holter monitor, it means that we can actually have a look at their whole day, and we can also track that and mirror that against what kind of things they were doing during the day. So were they getting ectopic beats when they were drinking coffee, for example? Were they having issues when they were exercising? Moving on from that, as I've already mentioned, exercise. So the exercise stress test, they're used to evaluate cardiac response to physical stress. These can provide information on myocardial response to increased oxygen requirements and determine the adequacy of the blood flow within the heart as well. Other investigations that we might see. So some of these investigations you're going to know. So oximetry, I'm sure you've all heard or seen or even put a pulse oximeter on to see the person's sats. We might be doing a peak flow within your lab, so you might actually see what is your flow of oxygen at the peak expiration. Arterial blood gases. Now, we're not really going to cover ABGs within this course, but you will be doing that when you move into second year. So I would really advise, if arterial blood gases can be quite difficult to get your head around, but once you do, everything makes a little bit more sense. So what I would say is, whilst we're not doing them in this course, it might be a really good point to stop and just have a quick, even Wikipedia understanding of what ABGs are, so then you have a base understanding when you move forward into second year. So some of the examinations, again, you will probably have heard of X-rays and CT scans, which are on there. So the bottom one there within the cellular examination of the lungs is thoracentesis. So this requires perforation of the chest wall to aspirate some fluid, and this might be to obtain a collection, a specimen to send off for diagnostic purposes, or it might be for a therapeutic benefit. We're now looking at the nursing cares that we might provide to patients with respiratory and circulation issues. Although we might not initially see health promotion as an important nursing care, I think this is sometimes because our mindset is often in the acute space. So it's really important to think about how we can stop patients coming into the acute care setting in the first place. So older people are by far the worst affected by influenza, with free vaccination programs for over 65-year-old patients being implemented since 2000. There are other programs for other vulnerable groups such as chronically ill, Aboriginal and Torres Strait Islanders. So make sure that when it comes to vaccinations that you know what is there to promote to your patient group. In 2009, it was estimated that 2.2 million people were vaccinated against the flu. There was an average of 13,500 hospitalizations due to the flu in Australia, but in 3,000 deaths, the over 50s alone. So there is clearly a real big problem for that age group. And in your small part, if you can educate those patients, then the more the better. Avoiding exposure to secondhand smoke. is essential to encourage your patients, and it might be that you have to educate your patients who might have children on the effects of secondhand smoke, because that sometimes can be quite difficult to broach the subject with various people, because we want to educate without feeling that we are being paternalistic and that we know best for everyone. But being able to have those conversations is going to be a really important part of your nursing. Patients are encouraged to eat healthy, low-fat, high-fiber diet, monitor their cholesterol level, their triglyceride levels, and their HDL and LDL ratios. If they can, reduce stress, exercise more to maintain a body weight in proportion to their height. I'm not going to stress that fact because clearly I don't listen to my own advice there. So let's move on from that one. So cardiopulmonary rehab can help patients to achieve and maintain an optimal level of health through controlled physical exercise, nutrition, counseling, stress management, which we've already mentioned, and possibly medications and oxygen compliance. Pursed lip breathing, which is the top picture there, that can be used to prevent alveolar collapse. This can be done by encouraging your patients to deeply inspire and then have a long, prolonged expiration through pursed lips. And then the bottom picture there, which is diaphragmatic breathing, and that requires the patient to relax their intercostal and accessory muscles while taking deep inspirations. So hopefully we've done our best to keep the patients away from the acute care area, but we might have to look after them in the acute care setting. In the acute care setting, dyspnea, which again is that shortness of breath, can be really difficult to quantify and treat. And it might be that we encourage proper coughing techniques, and that will keep the patient free from obstruction, as coughing will help mobilize secretion. So it's not always obstructions of what we put in, but it might be obstructions that are in our lungs because we're acutely unwell. If we're giving oxygen to our patients, and by that I mean more than 4 litres a minute of oxygen, we might want to humidify that oxygen and add moisture to that air, because it might be a lot more comfortable for them to breathe, especially if they're on the oxygen for a long time. So chest physio as well is a group of different therapies that can be used to mobilize pulmonary secretions. These can include postural drainage, which we'll have a look in a second, chest percussion and vibration. Normally this is done by the physiotherapist, so you might want to liaise with them. And if you get the chance on clinical placement, maybe spend some time with the chest physio and see what they actually do. So there you go, that's postural drainage, and we can see there that depending on how we position the patient, how we lie them, how we have the head of the bed, the feet of the bed, it will actually help with the drainage depending on where those secretions are coming from, what lobe of the lung. So the most effective position for promotion of lung expansion is the 45 to 60 degree semi-Fowler position. And that's because this position uses gravity to assist in lung expansion and reduces the pressure from the abdomen on the diaphragm. Patients can use incentive spirometry, which is that picture there, to prevent and treat atelectasis, and sometimes that's normally what we will give to encourage that voluntary deep breathing post things like surgery. Chest tubes we're going to mention in a moment, and you can see there's a little bit of a chest tube there, and they're to treat a range of things such as hemothorax, pneumothorax, which we'll mention in a moment as well. Hopefully you're never ever going to need these, but they're always good to know what they are. So we are going to be looking at these in your labs as well, so don't worry if you've never seen them. So a Goodell's airway, which is the top picture there, and basically that's used to the patient has still got a breathing, they can still breathe for themselves, but they might be unconscious, and therefore they might have obstruction of the trachea due to the tongue kind of flopping back in the mouth. So the Goodell airway is inserted in there to keep the tongue in place and to keep a nice open airway for the patient to breathe. A nasopharyngeal airway is very much the same as a Goodell's airway. It's maintaining an open airway for the patient to still breathe themselves, but it might be used if there is any trauma to the mouth or the jaw. So For example, if someone was in a car crash and they hit their face, we obviously don't want to cause any more trauma to the mouth, so we would put an airway through the nose. Other airways, now these are normally airways that we wouldn't put in as nurses, or we would have to have a lot more training to be able to use them, and they're your tracheal airways. So your endotracheal airway, and that's a picture there, the bottom one, that is going through the mouth, sometimes can go through the nose, and it's going to sit just as you can see where it's branching off into the lung, so it's sitting just above the carina of the airway, and it means that it's a little bit more permanent. We can attach a bag to that if we needed to bag them. So this is normally that the patient doesn't have any respiratory drive themselves and we're having to do everything, or we might hook them up to a ventilator. Now, if that wasn't any good, and this is more of a permanent fixture, we might have a tracheostomy, which is avoiding the nose and the mouth altogether and going through, I'm going to say the neck. It's not really going through the neck, but everyone would know where that was, and you might have even seen one in the movies. So some respiratory terminology, and I've mentioned some of these before. To treat these, you might be using a chest drain, but we're going to mention them here, but you're going to be covering them more when you go on to your second year. So a pneumothorax, so is a collection of air in the pleural space. So you can see there in the top picture, our lungs are essentially covered with another sac. So it's kind of like a balloon in a balloon. Now, if there is any air in that space, it creates a positive pressure because the inside that lung is actually a negative pressure, and it will actually start to collapse the lung down. Hemothorax, so same kind of thing as the pneumothorax, but this time it's a collection of blood within that pleural space. And the empyema, which is the very bottom picture there, is a collection of infection or fluid or pus in that pleural space. All do the same thing, all create a difficulty in breathing, they reduce the lung function, and it's something that we need to treat. Depending on the size of the pneumothorax, you might even just treat that with 100% oxygen, but a lot of the time you're treating with a chest drain. And there is a chest drain. So you can see on the right, which is a nice fancy closed system, and that's probably what you're going to see out in the real world. But to understand what that does, there's a few pictures there that kind of explain the chest drain system. If we look at that picture A, we can see there's a bottle, it's got some fluid, and it's got a tube out to the world and a tube to the patient. Now, the reason that we have that water and we have an underwater sealed drain, because if I was just to connect a tube into my patient's lung to get rid of the air, the problem is air can go out of the lung, but it can also come back. But if I put that tube underwater, it takes a lot of pressure for the patient to be able to suck that water up the tube into their lung. So what it does is it kind of acts a bit like a valve. So air can come out and you'll often see bubbling in that water, but then when air tries to get back in, it can't get through that water seal back to the patient. Now that's great, just having the one bottle, but sometimes what can happen is if you've got, say, an empyema or a hemothorax, so you've got blood, if blood's coming and filling up that bottle, we're going to need a little bit more than just that one bottle. And that's when we come into the picture B and the picture C, so either a 2 or a 3 bottle system. And if we look at picture C, we've got the drainage bottle, so that's where the blood is coming. And we've got a water seal, so that's creating that valve, and we might even have a bottle that's connected to suctioning on the wall. Now, like I said, this is just for you to know, so you go, yep, I remember that word, chest drain, but we're not really covering that in any great detail in this course. You'll be doing that when you move into second year. This is just to have an understanding of what you might see. So suctioning, we are going to be looking at suctioning within your labs, and when we're looking at suctioning, you can see there that that little boy is having some oral suctioning, and this isn't, or it shouldn't be, a routine thing that we're doing. We're only doing it because the patient has a need or requirement. So it might be that they have an ineffective cough and they can't actually get something out of their mouth. We might need to send a specimen away. Now, it should be remembered that when we're suctioning, we're going very close to where someone, hopefully we're not going into someone's lung, but we're going very close to where that lung is. So as well as suctioning out whatever we need, we're also suctioning out oxygen from the patient as well. So when we're doing suctioning, we should be doing it in short, sharp bursts and then letting them reoxygenate in between each suctioning attempt. So we can see the different types of suctioning that we might be involved in. The ones that we are going to be doing is oropharyngeal or nasopharyngeal, and we might be using a Yanker sucker as well in the mouth. And a Yanker sucker is that kind of suction device that you've probably seen in the dentist when they're getting all that spit and water out of your mouth. The one that we're not going to concentrate on, because this is, I would say normally, but I think 95% of places I've worked in, tracheal anything, so changing tapes or suctioning through a tracheal tube is normally something that you would have to do extra competency on. So as a student, I would highly encourage you to stay away from any tracheal cares because you won't have been taught that and therefore it's outside of your scope of practice. So like I said before, suctioning is not a routine procedure, only when needed. So you might actually hear that they're a little bit rattly and they've got some secretions that they need to come up. You might actually see them when you're listening to them. So when you're auscultating their chest, they might have reduced breath sounds. So you think, okay, well, I obviously need to suction to increase the ability for the air to get into the lungs. So remember, make sure that you're not doing it routine, only when the patient needs it. And you can see the very bottom one there, suction-induced hypoxia. And that's when we're in there suctioning for too long and we actually suck out all the oxygen from the patient as well as the secretion. So short, sharp bursts, and again, we'll cover this in labs when you go through there. Oxygen therapy is also something we're going to cover in labs. Now, the goal of oxygen therapy is obviously to relieve hypoxia, which we can't physically see, but relieve those signs and symptoms of hypoxia that we've had a look at earlier when we had a look at rat bed. So some of the methods that we might see to deliver that oxygen. So nasal cannula is going to be your mainstay of oxygen delivery, and the reason being is that you can give oxygen but the patient can still eat and talk and it doesn't really overly affect them. The problem being that if you think about that air whooshing up your nose, that can dry your mucosa out. So make sure you're looking after the patient's nares and their comfort as well. A Hudson mask is your standard simple face mask. It needs to have a good fit to have a good oxygen delivery. If I wasn't getting increase in my saturations with the nasal cannula, I might move on to a Hudson. Now, the Venturi mask is a little bit of an old school mask, and you actually can dial up the amount of oxygen that you can deliver to someone. It's a bit old school, but I put there because some places you might see them. You might see them for, in certain respiratory wards with patients with COPD, for example, but they're kind of phasing out. Now, the very last one is a partial and a non-rebreather. Now, I'm not going to go too much into these because you'll see them in your labs, but these are to try and deliver a much higher concentration of oxygen. So I've tried my nasal cannula, the SATs didn't improve. I've tried a Hudson, that didn't improve. I've now gone to a partial or a non-rebreather, and that is the most I can do for a non-invasive oxygen delivery. So we can see here the link between the delivery device, how much we can dial up at the wall, so how many litres per minute we can give at the wall, and how much percentage of oxygen they're actually breathing in. So roughly room air is about 21-22% oxygen, and we can see there that 1 litre of nasal cannula only increases that by a couple of percent. Now, also on this, you can see that after 4 litres of oxygen by nasal cannula, we really then need to move to a simple face mask. After about 6 to 7 litres on a simple face mask, dialing it up any more is not going to increase the percentage of oxygen. So rather than going up to 15 litres via a simple face mask, I need to then think, do I need to go on to a partial rebreathe? So again, we'll be covering these in greater detail in your lab, so bring any questions that you might have. So the last thing I'm going to say here is the restoration of cardiopulmonary functioning. If hypoxia is severe or prolonged and the patient collapses, this is where you're going to have to then go through your doctor's ABCD, which hopefully you've all done your basic life support training, and this is when you're going to have to commence CPR. Again, I'm not going to focus on this because you should have all had CPR training. You should have all uploaded that onto Sonia. But this is kind of the end bit. So always be prepared if you've got a patient in respiratory circulatory distress that this might be something that you need to draw upon later on.